Good evening, one and all. Thank you for joining in this session. In this webinar, myself, Dr. Mahendran, School of Physiotherapy, Faculty of Health Sciences from MAHSA University. In our faculty, we have three levels of program: diploma, degree, as well as masters. In masters, we have part-time as well as full-time programs. So if you are very interested, then you can visit our university to see what all the facilities which we are having with us. Or else we can visit our website www.masa.edu.in. Okay. Now, in our today's topic, stroke rehabilitation. Here we have Dr. Shanta, our expert. He also working as a lecturer in our university, and he has completed his Master of Physiotherapy in 2000, in the year 2000, and also he has completed his PhD in the year 2017, and then he has more than 21 years of academic as well as clinical experience in this field. I think he's the right person to give a talk about this topic. Let's call Dr. Shanta to share his ideas.
Thank you for joining this webinar session. In this session, I am going to talk about the basic evaluative methods what a physical therapist can do for a stroke patient in acute and early subacute phase. Let me share slides. What is stroke or cerebrovascular accident? It is a rapidly developing clinical science of focal or global disturbance of cerebral function lasting more than 24 hours or leading to death with no apparent cause other than that of vascular origin. What are the common risk factors for stroke? One is hypertension, cardiac disease, diabetes, blood lipid levels, cholesterol, smoking, obesity, oral contraceptives, and in the developed world, now air pollution has also become a risk factor for ischemic stroke. Vegetarians are 20% higher risk of getting hemorrhagic stroke when compared to meat eaters. There are two major types of stroke. One is ischemic, the other one is hemorrhagic. Ischemic stroke, a clot blocks blood flow to an area of brain, and ischemic stroke can be of two. One is a thrombotic and the other one is embolic. Hemorrhagic stroke, bleeding occurs inside or around brain tissue. Hemiplegia, paralysis confined to one side of body or simply weakness on one side of body. Middle circulatory stroke. This is a very common type of stroke often seen in acute care setups and physio departments and even in the community rehabilitation centers. In middle circulatory stroke, upper limb will be more affected when compared to lower limb. Distal functions will be more involved when compared to proximal functions. So they'll have difficulty in using the hand. Early usage of hand will be affected in the acute care, acute rehabilitation part. Okay. Anterior cerebral artery stroke, the patient may end up in paraparesis, where a part of trunk and lower extremities will be affected, or lower limb will be more affected than upper limb in one side. The weakness is on one side of body. But the proximal function here, the proximal function will be more affected than the distal. The difficult patient to handle in stroke variety is anterior circulatory stroke, and this is also a very rare type of stroke. Brainstem stroke, vertigo, severe imbalance, double vision, slurred speech, and decreased level of consciousness is often seen in this type of stroke, and weakness on one side of body. The features of upper motor neuron syndrome may be characterized into two broad groups: the negative phenomena. And in negative phenomena, there will be reduced motor activity. The common features are weakness, loss of dexterity, fatigability. Whereas in positive phenomena, the associated features, um, there will be increased motor activity here, and the symptoms often seen with the features spasticity. What is spasticity? Spasticity is the neural component of hypertonia and is velocity dependent, which means that the faster the muscle is stretched, the greater the resistance is felt. What is hypertonicity? Hypertonicity, there will be disinhibition and there will be neural change, and there will be plastic reorganization and adaptive features also included there. So all three combine to form the hypertonicity. The next feature is clonus, associated reactions. Normal movement is dependent upon constant interaction of neural structures within the central nervous system. This neural activity may be associated with a series of cyclical events. If there is any interruption in this cycle of events, the patient may have difficulty in doing movements. Generally, the outcome is going to be affected. If there is an increased or altered postural tone because of neurological damage, the patient will have a disordered movement control, or you will be able to do only limited movements. And this will produce abnormal sensory input into the central nervous system. And because of the abnormal sensory input, the quality of movement is going to be affected again. And if the patient is going to put a lot of effort and a lot of compensation happening, this will lead to abnormal postural adaptation. Effective assessment is a key to effective practice. Once the patient is clinically stable, normally in ischemic stroke, neurologist or general practitioner, they will refer the physiotherapist, the stroke patient within 24 hours time. Sometimes it may even take 48 hours to refer the patient for physiotherapy. But in hemorrhagic stroke, the referral to physiotherapy may take more time, where physiotherapists can encourage minimal activity because the patient won't be allowed to sit for long period. That's why in hemorrhagic stroke, the rehabilitation program is going to be slightly delayed. So minimal activity in the acute care. First step patient therapist should do is positioning the patient side lying with adequate pillows or supine. There are studies that support side lying is a good position in that can be given to stroke patient in early rehab. And evaluate the motor control of arm and leg. We can use National Institute Health Stroke Scale to evaluate voluntary control of arm and leg inside intensive care unit or neurology ICU. Evaluate the cognition. In cognitive assessment, evaluate the orientation, attention, concentration, and language. At least evaluate the attention component inside intensive care unit, and also check the language, whether the patient has got a comprehension. Check whether the patient is a aphasic. In attention, maybe we can tap the extremity and ask the patient how many times you are tapped, or you can ask the patient to spell the word world in the reverse order or backwards. Sensation that you can test. First assessment to do is pain test, and you can use pin to check the pain sensation, and evaluate joint proprioception, at least distal joint proprioception, For example, in upper extremities, you can instruct the patient to show the affected thumb with the unaffected hand. Okay, so that's how you can simply test the joint proprioception in acute stroke patients. So, how can you test the motor control of arm? Just ask the patient to stretch the arm outwards. In case if the patient has difficulty, you can support the extremity, take the arm to 90 degree. Instruct the patient to occlude the vision and ask him to hold the arm in that position. In case you see the extremity going down in one side, then that side is affected. So you can grade it like using this drift. Okay, drift is scored in the arm if the arm falls before 10 seconds. So it can be no drift if the patient can hold for full 10 seconds. Uh, there can be drift down before full 10 seconds. Then you can give a grade of 1, and some effort against gravity. So the patient can do hold for a few seconds, then you can mention it as some effort against gravity. So you can give a value of 2, and 3, no effort against gravity. And finally, if there is no movement, if the patient cannot do any movement, then you give a score of 4. And next scale is the only scale that can be used to evaluate the severity of stroke, and you can also predict recovery in stroke patients. There are also other evaluative tools available like augmented prognosis scale that can be used in geriatric patients. How can you evaluate motor control of leg? The same way, instruct the patient to flex the hip to 30 degree and ask the patient to hold in that position for 5 seconds. You can also ask the patient to close the eyes. Okay. So a drift, leg falls by the end of 5-second period, you can give a score of 1, or if the patient can hold for all 5 seconds, then the score will be 0. 2, leg falls to bed by 5 seconds, but has some effort against gravity, value of 2. 3, no effort against gravity. And 4, no movement. So you'll understand how severe the involvement is by doing this test. Many mental state examination. Evaluate the registration item. You can show 3 objects like apple, table, and penny, and ask the patient to tell all the 3 objects. Ask him to name the objects, and then test the attention. Already I said you can ask the patient to spell the word in backwards, or you can tap and number of you ask him how many times you tapped on the hand. Okay. And after evaluating attention, again ask the patient to tell what are the objects learned before, like apple, table, and penny, which you showed in the beginning. So that is to evaluate recall. So it can be like immediately recall, or can be after a short term or long term period. You can ask that. Okay, so evaluate the recall item. Language, maybe you can ask the patient to use the right index, ask him to touch the nose, and then to touch the left ear. So 3-stage commands can be evaluated, or 3-step commands. Why should you do 3-step command evaluation using this mini mental state examination? Because if the patient is not able to follow even one command, then the therapy, whatever instruction you are going to give to the patient, is not going to help. So the therapy is going to be very minimal if the patient can follow only one command. If the patient can follow 3 commands, then they will be able to understand what you say, and you can also test the comprehension. Okay. And copying skills, yes, you may use intersecting pentagons or intersecting triangles. You can modify and you can test the copying skills. Brunnstrom stages of recovery. So in the stage 1, in stroke patients, is the flaccid stage or flaccidity, where the patient won't be able to do any movement. So the voluntary movement is affected in stage 1. Stage 2 is the early spastic stage, where the patient will be able to do a little bit of movement, but more of flexion in the upper extremity and extension in the lower extremity. That is stage 2. So spasticity starts to appear. So initial stage of spasticity, stage 2. Stage 3, increased spasticity, where the patient will be able to do flexion movement or bending movement in the upper extremity. And he'll be able to extend the knees and hip in the lower extremity. So that is a stage of spasticity. And stage 4, the spasticity will start declining, and now the patient will be able to do movement away from the synergy pattern. So he'll be able to do flexion at the stage 3, and stage 4 he'll be able to break up the flexor synergy, and he'll be able to do extension the upper extremity and lower extremity. He'll be able to flex the knee also in the stage 4. And stage 5, complex movement combinations will be done by patient. So he'll be able to do little bit coordinated movements in stage 5, where he'll be able to flex, extend, and he'll also be able to do forearm movements comfortably, wrist and finger movements, and finer task will also be the patient will be able to do finer task also in the stage. And stage 6, the spasticity completely disappears, and now the patient will be able to do all movements voluntarily controlled. Okay, now in stage 7, normal movement comes, and now the voluntary control and the control of arm completely returns in the stage 7. What are the flexor and extensor synergy pattern of upper extremity? Flexor synergy pattern of upper extremity. The patient, if you ask the patient to flex the arm, okay, he'll do a shoulder movement. When he starts to do the shoulder, move the shoulder, there'll be retraction of scapula, elevation of the girdle, and there'll be external rotation, abduction to 90 degrees, and there'll be a flexion of elbow to 90 degree, and full supination. So this is the flexor synergy. If you ask the patient to flex the arm, he'll be doing like this. Okay, so this is the flexor synergy of upper extremity. And the extensor synergy of upper extremity, he'll keep this scapula in protracted position, and he'll do internal rotation of shoulder and abduction. He'll be doing adduction of arm and extension of elbow, which will be complete, and he'll be able to do full range of pronation. Whereas here, the flexor synergy, there'll be full range of supination. Fickle-Mayer motor assessment of upper extremity. This is tested in sitting. Already explained about the flexor synergy and extensor synergy. And you are going to test the same synergy pattern using the Fickle-Mayer upper extremity assessment. Just instruct the patient to salute the ear with the affected side, the ipsilateral side. He has to bring the hand from the same side, ipsilateral lap, and he has to touch the ear. He has to salute. Now, you will be evaluating the retraction, elevation of shoulder, external rotation, abduction, supination, elbow flexion, and also wrist extension. This component can also be evaluated using the flexor synergy pattern. And then instruct the patient to touch the opposite knee, where he is going to do adduction, internal rotation, elbow extension, forearm pronation. Okay, so that's extensor synergy. So next, after evaluating this, test the voluntary movement of mixing synergies. Okay, now evaluate, test whether the patient can take the hand to the lumbar spine. Most of the stroke patients in the acute and the early subacute phase, they won't be able to do this movement, but this has to be tested. If the patient can take the hand to the lumbar spine, that means the patient has already gone into stage 4 to stage 5. Okay, so if the patient is in stage 4 recovery, he will be definitely able to take the hand to the lumbar spine. But this assessment is not done by most of the physiotherapy centers. So this is a hemiplegic patient. The duration of the condition is only 10 days after stroke. Elderly patient. So he was able to take the hand to the lumbar region. That means he is in the stage 4 recovery. Next, evaluate shoulder flexion to 90 degree from neutral. Ask the patient to flex the shoulder to 90 degree. Observe whether the patient also does abduction and elbow flexion, and also evaluate for the internal rotation. So each and every component can be assessed using just instructing the patient to do 90 degree shoulder flexion. And then let the patient flex the elbow to 90 degree, evaluate supination pronation. This has to be tested inside the intensive care unit itself. The very first day you assess the patient. So why we have to evaluate supination? Because if the patient can do supination, that means he has already gone into very good recovery phase. Okay, that's why supination component is very, very important. And flexor and extensor synergy of lower limb. Flexor synergy of lower limb, this has to be tested in supine line. Instruct the patient to flex the hip, and automatically you'll see abduction, external rotation of hip, flexion of knee, and dorsiflexion in inversion of the ankle happening, and dorsiflexion of toes. So that is the flexor synergy you'll see in stroke patients. And then extensor synergy, you instruct the patient to extend the hip, adduction, internal rotation of hip, extension of knee, plantar flexion, inversion of ankle, plantar flexion of toes. You can also put your hand under the toes or support the plantar surface of the patient to push against your hand. So you will be able to check whether the extensor synergy is complete or not. Same way, you can put your hand there in the dorsum and evaluate the flexor synergy. Mayer assessment of lower extremity, same way, just instruct the patient to flex the hip, knee, and then ankle. And you will also evaluate the abduction and then the rotation components and instruct the patient to extend the knee. Okay. And evaluate the voluntary movement of knee flexion and ankle dorsiflexion in sitting. And then voluntary movement in standing, evaluate knee flexion and ankle dorsiflexion in standing. Functional independence measure. The personal care activities like feeding, grooming, bathing, dressing, toileting, all these items can be tested using a 7-point ordinal scale, which will go from complete independence to total dependence. So it is evaluated using a 7-point ordinal scale. Sphincter control, bladder management, and bowel management separately evaluated using the same ordinal scale. Mobility, locomotion, communication, where comprehension, expression evaluated, social cognition, social interaction, problem solving skills, memory, all can be tested using functional independence measure. Phases of stroke rehabilitation. Acute phase. First 7 days is the acute phase of stroke rehabilitation, which will start there in the neurology intensive care unit. And if the patient is clinically stable, the patient will be sent to neurology department or to the neuro ward, and patients will be treated by physical therapists in the neuro ward. And later, the patient can also be taken to physio department if the patient is able to do little bit of sit to stand tasks. So after evaluating all these components, neurologist and physical therapist will decide whether the patient can be taken to physio department or not. Early subacute phase, 7 days to 3 months. The therapy, the assessment and the therapy the physical therapist offer to patients, it has to be the duration has to be increased, the number of therapy sessions has to be increased, and because most of the stroke patients in acute and early subacute phase, they will be inactive. They won't participate in rehabilitation. So we have to force them to do exercise. So this is a fruitful period where the patient has to do a lot of movements to get good recovery. Late subacute phase, 3 months to 6 months. Chronic phase, more than 6 months, the chronic phase. So inside intensive care unit or in the neurology ward, if you want to make a patient to sit, how can you assist the patient to come up to sit? On no cost, do the movement totally a passive. Don't do a passive program for the patient. You have to assist. Just flex the hips and flex the knees, and you can put your hand there in the pelvis. On the other hand, the proximal arm will support the upper trunk, and you can ask the patient to laterally flex the neck, the affected side, and lateral flexion of the trunk should be encouraged, and also patient to come up. And you can also encourage the person to put a little weight through the affected upper extremity also. Okay. And this how you can make the patient come to sitting with assistance. So again, I repeat, it is not a passive program. You have to assist the patient to come up, and the patient should actively participate to come up to sit. So side lying is the best position. Always turn the patient to the unaffected side. Always turn the patient to unaffected side, and you can use the proximal arm. use the proximal arm to support the upper trunk, and the distal arm can go to the pelvis. In case if the patient is not able to do lateral flexion of neck and trunk, and is not able to put weight through transfer weight through the arm, then uh, you can put one hand there in the greater trochanter region, flex the hips and flex the knees slightly, and hook your elbow against the distal thigh. And what you have to do is just give a mild pull to the pelvis downwards. Okay, and instruct the patient to laterally flex the neck trunk. So that's how you can make an acute stroke patient to come up to sit, or even the patient has got very little function. You can encourage the patient to come up to sit in this way. And this can also be taught to the nursing practitioners in the intensive care unit, or to the nurse available in the neurology ward, and the patient attenders can also be taught this application, because this is very important in the acute phase. Because if the patient go on use the unaffected extremity, the patient will start using the unaffected and he won't use the affected extremity. And the other problem is, if you allow the patient to pull the affected extremity, they may injure the soft tissues of the shoulder. So the hand should be there in the greater trochanter region. Just pull the pelvis slightly downward and instruct the patient to laterally flex the neck and trunk, and then assist the patient to come up to sit. Physical therapy in the acute phase start with positioning, either sideline or supine. And in positioning very early in the ICU, encourage the person to transfer more weight into the scapular region of the affected side if the patient is in supine. And you can keep a pillow below the thigh, and this should go to the mid calf, and the pillow won't allow the extremity to go into more lateral rotation, and the upper extremity can also be supported with the scapula in slightly protracted position. And then passive exercise. If the patient cannot do any active movement, then you can give passive exercise. And no cost, don't move the shoulder beyond 100 degrees, and it should not be a forceful movement. So as far as possible, passive exercise, you give passive exercise to glenohumeral joint. Don't push the shoulder above 100 degrees. Encourage active exercise. So very early, encourage the patient to do active exercise. Either if the patient can do abduction, encourage abduction, and keep the arm at 30 degrees. Encourage the patient to do lateral rotation very early. In case of the patient is not able to do active exercise, then active assisted exercise can be encouraged very early. And then bridging exercise, where the patient is going to put weight onto the both foot and he is going to lift up the hips. Unilateral bridging, that's isolated bridging. This can be started where you can encourage the patient to put weight into the affected side and lift the hip. The other extremity has to be extended. Encourage active dorsiflexion range of motion exercise very early in the ICU. Rolling exercise to the unaffected side and also to the affected side. It has to be taught to the patient very early. So now, how can you do isolated hip extension? This is very important in the acute and early subacute phase. So what you can do is you keep a small block by the side of the bed. Now the patient can put weight onto the affected extremity. You put your hand there in the hip extensor. Now instruct the patient to do isolated hip extension in the affected side. Upper extremity training. Again, I repeat, no forceful passive range of motion exercise. Improve the scapular stability. So, early weight bearing in supine, and even when you try to bring the patient come up to sit, You can encourage the patient to put weight into the affected hand, and then weight bearing sitting and weight shifts to the affected arm will also improve the scapular stability. Shoulder abduction range of motion exercise, shoulder external rotation range of motion exercise, reaching in supine and sitting. Very early, teach the patient reaching task. So he has to learn how to hold the arm by elbow in extension, how to bring the glenohumeral joint forward, how to move the scapular girdle upward or forward. Okay. And then also teach the patient to extend the wrist, and extension of fingers should has to be taught very early. This has to be first taught in supine and then in sitting. Arm sling. In case of the patient has got weakness there in the upper extremities, and if there is any possibility of subluxation, to prevent this very early, you prescribe an arm sling to stroke patients. And always give a static splint very early. And once the patient recovers, you can also use dynamic hand splint to strengthen the weak musculatures of hand. So shoulder abduction range of motion exercise, encourage shoulder abduction. And in case of the patient is not able to do abduction properly, you can also tap on the shoulder abductors and encourage the patient. And you can use friction-free surface to do shoulder abduction range of motion exercise also. You can also use re-education board to reduce the friction. So already I explained about the reaching task. So what you have to do is, first, support the proximal part, encourage the person to go for reaching. He is not only trying to reach, but also is going to protect the shoulder girdle. And he has to keep the elbow in extension. So first assess this. And later on, if the patient can hold the arm in the position, now you can put your hand there, the distal, and encourage the person to go for object, or you can ask the patient to touch your other hand. Stroke patients, very often they'll have poor scapular control. The scapula will remain depressed and little retracted all the time. So in case if the patient has got poor scapular control, so what you can do is you can put your hands against the patient's hand and ask patient to push your hands forward. Okay, and you offer mild and then increase the resistance slowly, and let the patient push your hands so that the scapular girdle control can be improved. This can be used to improve the proximal stability and also scapular girdle control. Okay. So the big disadvantage stroke patients have in the acute and early subacute phases. Normally, when a person tries to lift the arm by the side, glenohumeral component, where when the arm reaches 90 degree, the glenohumeral component will normally help the person with 60 degrees of movement to reach 90 degree. And the initial phase, the scapula won't move much. It will get fixed against the rib cage. So first function needed for the person to do abduction is setting phase of scapula, where the patient should have very good scapular stability. Whereas here in stroke patient, the stability function will be lost. So you ask the patient to do abduction, immediately the scapula will also start moving along with the arm, along with the glenohumeral segment. So the stability is lost in stroke patients, the acute phase. So we have to encourage this sort of exercise to improve the girdle stability and then to improve the proximal. In case if the shoulder muscle is weak, you can use approximation technique, where you can use the proximal arm to support the elbow. You can put your hand. You can offer resistance through your hand. Ask the patient to push forward, and you will be able to improve proximal control. In case the proximal muscles are weak, you can apply approximation technique. So this patient was able to take hand to the posterior superior iliac spine. And later on, he was able, when we gave this proximal stabilizing efforts, approximation, and then scapular stability exercise, he was able to take the hand to the even to the lumbar region. And after the application, he was even able to take the hand to the even the thumb reaches the inferior angle of the other side scapula. So that's how the scapular stability exercises can help, and the approximation technique can help the patient to do good internal rotation. Most of the stroke patients won't be able to do this. Positioning to stretch glenohumeral adductors and internal rotators of shoulder. Just instruct the patient to put the hand at the back of the head and then ask the patient to take the elbow down to the bed. This will stretch the pectoralis major adductor of the shoulder. So weight bearing to shoulder can be given in slight extension, and avoid weight bearing in more extended arm. Don't give weight bearing in extension and external rotated position, because antero-inferiorly the capsule is lax, so there is a possibility of causing injury to the soft tissue. So avoid giving weight bearing in extension, external rotation. Maybe in few degrees extension, you can encourage the person to do weight bearing. And weight bearing can also be encouraged with the side of the hand, can be placed with the side of the body, and even in flexion. The weight bearing flexion will facilitate the subscapulary, which is internal rotator of shoulder. In subacute phase, when you instruct the patient to do shoulder flexion, this was evaluated 2 months duration, and here you can see this is the flexus energy of arm. Okay, what is a concrete and abstract exercise? You just instruct the patient to do wrist extension, wrist flexion, shoulder abduction. Those are all abstract exercises. So what you can do is, if you want to train up the wrist radial deviators and extensors, you can give a block. You can give a block and instruct the patient to take the block. Let the patient bring the top of the block up this direction, and then also teach the patient to slowly control the activity. Let the patient take down the block very slowly. That will improve eccentric control of the radial deviators and wrist extensors. Okay, so that is concrete exercise. So you can give a block. Otherwise, you can keep a drum by the side, or a small book like thing. You can give a block. Suppose you want to improve supination. Let the patient keep the elbow 90-degree flex. You can give a pen or a block and instruct the patient to take the top, and he has to bang this again. So he has to strike the object with the top of the block. Okay. So this is a concrete exercise, and encourage more concrete exercise for stroke patients, even the acute phase. So hand function, generally we will evaluate lateral prehension. We will evaluate the spherical grasp, hook grasp, and then we have to even evaluate the muscular force. So a handheld dynamometer can be used to test the muscle force. What our force the patient can deliver through the hand can be tested using a handheld dynamometer. So the pinch grip can be tested using the dynamometer this way. So how can you encourage a person? This can be started in the intensive care unit itself. If the neurologist is ready to refer the patient, this can be started in the intensive care unit, or you wait for 1 or 2 days, and then you can take the patient to neuro ward, and you can start the sit to stand task at the neuro ward. So what the therapist should do is just put the best space hand against the distal thigh of the affected leg, and then instruct the patient to look up all the time. He has to keep the trunk straight, and each and every time when the patient tries to come up, allow the knee to translate forward and instruct the patient to come up. And when the patient goes back and sits on the chair or bed, now again allow the patient to translate the knee slightly and then go and sit back on the mat or the chair. Okay. And then you can give a structured environment like this. You can keep a table in front, and then the patient can also participate sit to stand task. This can also be taught to the nurse of a neuro ward, even to the attenders. They can also train the patient to do sit to stand test task very early. In case if the patient is little hefty and the patient has difficulty in coming up to stand, you can also follow this method where you can keep the knees, both right and left knees, on the either side of the affected knee. Now allow the patient to translate the knee forward. On no cost, don't block the affected side knee. That may cause injury to the soft tissues. And here you can see the right upper extremity is affected. That's why I'm supporting the right upper extremity. And immediately after the therapy, keep a pillow, always support the arm with a pillow and don't allow the arm to hang. That might cause soft tissue injury. And early mobilization. What are the other products we have or other equipments the therapist can use? Once the patient is allowed to train up in the neuro ward, a body weight support, a harness can be used in the neuro ward itself. So here the harness is fixed. Now the patient won't have any fear of fall. So he will be able to transfer weight to the right and left lower extremities, and he'll be able to start doing walking with the support. So that's the advantage we have with the harness. And you can also encourage the person to shift weight to the affected extremity, and you can also teach the patient to reach for objects. So both the tasks can be done at the same time. So you are also training up the standing, the weight shift to the affected side, and also reaching. So those whole tasks is very important in the early phase of stroke rehabilitation. In case if the patient has got difficult elderly, you treat an elderly patient, you put your hand there in the pelvis and you make the patient now walk. You make the patient walk. Now the weight shifts to the affected and then to the unaffected extremity. When the patient shifts weight, the pelvic will also move slightly to the right and left side. And in case you put your hand there on the pelvis, you will restrict the movement. You won't allow the person to shift weight to either sides. Now you can use a belt like this. You can fix it in the lower trunk, and you can make the patient walk. Now you are not going to restrict the patient's weight shift to the affected and then to the unaffected extremity, and he is going to do a normal walk with this type of belt. Now you can use a block. You can keep a block, and the patient can put the affected extremity on the block. You can keep your waist space above the knee, and that is the distal thigh. Encourage the patient to come up, and you can strengthen the quadriceps musculature this way. The block can be placed by the side, and you can instruct the patient to put the affected extremity on the block. And lateral step ups can also be encouraged to strengthen the hip abductors. The common problem list seen in the subacute phase: abnormal coordination of movement patterns, poor balance, sensory deficiencies, abnormal muscle tone. Theory of motor control will help the therapist to understand and explain motor skill performance. So you will be able to understand the constraints or limits, what are the limits the patient has got, limitation the patient has got, potential of the patient, the deficits, motor deficits of sensory involvement the patient has got, all can be evaluated once the therapist is thorough with their theories of motor control. And this will enable the therapist identify the performance problems, develop intervention strategies, predict effectiveness of intervention strategies, develop systematic approach, create new intervention strategies, evaluate the effectiveness of intervention applied on that patient. Those are the techniques physical therapist has to learn, master that, and apply that in stroke patients. It all depends upon the assessment, and after evaluating the patient, the therapist can decide what technique can be applied for that particular patient. So it's an individual tailored assessment and management. So motor relearning program. Here, the therapist is going to analyze the task, find out the missing components, and then compare it with the essential components. And eccentric control is given utmost importance in the motor relearning program. Continuous movement therapy, where the the patient is not allowed to use the unaffected extremity, encourage movements more in the affected extremity. Neurodevelopmental therapy, here the symmetry has to be maintained all the time in the early rehabilitation. Brunnstrom technique, in case of the patient has got difficulty in breaking the plexus synergy pattern because of weakness, suppose there is a weakness in pectoralis major musculature, then the irradiation program, the resistance can be offered to the unaffected extremity, and you can facilitate the weak musculatures, and you can help the patient to break the plexus synergy very early using Brunnstrom technique. And proprioceptive neuromuscular facilitation, this technique, we have diagonal patterns. This can be taught in lying first, and then you can apply this in sitting also. Encourage D1 extension pattern very early, and encourage the D2 flexion pattern of the lower extremity very early in the neuro ward. Roots approach, in case the patient is not recovering, roots approach can also be tried. There, the icing can be applied to induce tone. You can encourage approximation technique. Attraction principle can also be used to facilitate the flexus. And the constraint dismovement therapy can also be a little modified therapy, where the duration of hours of restriction of the unaffected extremity can be reduced. So there is modified way of applying constraint dismovement therapy. Mirror therapy, this will give a visual feedback. And the disadvantage of constraint dismovement therapy and mirror therapy is the patient should have some voluntary control. Only then you can apply mirror therapy and constraint dismovement therapy. Functional electrical stimulation, yes, this can be given to patient very early, but we have to evaluate the sensation. Once the sensation is tested, we can start functional electrical stimulation. We can try to rehabilitate the hand as well as the dorsiflexion eversion activity very early. Robotic therapy, in case of the patient is not able to function, even in spite of all these approaches, then the option left is robotic therapy, where the patient will be made to do the movement number of times. The repetition plays very important role in robotic assisted rehabilitation therapy. Once the patient starts doing sit to stand, little function improves the patient, and the neurologist is happy with the patient's progression, the patient will be allowed to train there in the physiotherapy department. So what we have is a functional mat. So the basic principle is always shift the patient to a mat. A functional re-education can be given to acute stroke patient or early subacute stroke patient in the mat, and encourage the patient to do rolling, and encourage the patient to go into sidling to both right and left side, and then the patient can go into prone lying. And the advantage is, in case of the patient develops tightness there in the rectus femoris, patient develops tightness there in the hamstring, or pectoralis major. All those tightness can be reduced using the functional mat exercise, and passive elongation of soft tissues has to be tested here in the mat in the very first day. And then you can put the patient prone kneeling, encourage the patient to shift weights both lower extremities and then to the upper extremities. And in case of the wrist flexor tight, that can also be reduced using the weight shifts. And balance can be improved in the mat, and later on you can make the patient to kneel. There can also be one more therapist with you to support the patient can do kneeling, and he can also practice hip extension in kneeling. That's the best exercise that can be taught to early subacute stroke patients, and this is very important for walking later on. And then once the patient learns it to stand effectively in the mat, you can shift the patient to parallel bar, where the patient will have visual feedback, and you can mobilize the patient in the parallel bar. And strengthening lower extremities can be strengthened using a static bike, where the height of the seat can be first raised. In case you treat an elderly patient, the height of the seat should be raised, and let the patient do minimal therapy here in the static cycle. And once the patient function improves, once the lower extremity gets stronger, you can reduce the height of the chair so that you can effectively strengthen the lower extremities. And later on, the patient can do better walking. You can put the patient in treadmill and strengthen the lower extremities and improve the walking function in the treadmill. Is accurate prediction of gait in non-ambulatory stroke patients possible within 72 hours post-stroke? Accurate prediction of independent gait performance can be made soon after stroke using two simple bedside tests. Evaluate the sitting balance and strength of the hemiparetic leg. Test the knee extension. So, if the patient can do sitting and the strength improves in the lower extremity, particularly the quadriceps, then you will. This knowledge is useful for making early clinical decisions regarding treatment goals and discharge planning at hospital stroke units. So, this type of prediction can also be done, and if you want to predict functional improvement in stroke patients, Brunnstrom recovery stages can be used directly. National Institute of Health stroke scale, and the other scales like Orpington prognostic, where you will test the motor deficits, arm balance, sitting and standing balance, and then proprioception and cognition. Cognition can be tested. All four components can be tested, and you will be able to find whether the patient fits into a mild, moderate, or severe stroke category. In case if the patient falls into very mild category, very early therapy can be started. Encourage the patient to do a lot of strengthening exercise very early so that the patient will have very good functional improvement. But this Orpington prognostic assessment can be applied only in geriatric patients. Thank you very much.
Ah, thank you, Dr. Shanta, for wonderful speech given in the topic of stroke rehabilitation. I think all the viewers can be able to get plenty lot of ideas on the topic of stroke rehabilitation. So I can be able to see there are many comments in the form of question are coming. So if viewers, if you have any questions, if you want to ask, you can put it in the comment box. Also, you don't forget to fill up the survey form that will make the betterment of the upcoming services. So now we are entering into the Q&A session. So the first question asked by Mr. Arun PT. So what do you think about stroke recovery prediction scales? Which one the scale is most valid based on your experience, doctor?
Uh, the Nick scale was the only scale available in 1990s, and even now that is an effective tool to evaluate or you can predict recovery in acute stroke patients. And Orpington prognostic scale, already explained about Orpington prognostic scale, that is also a very valid assessment that can be used to test the recovery in acute stroke patients. And don't forget about Brunnstrom recovery scale, which was introduced in the year 1954-56 after testing two rehabilitation centers. Till date, no scale is effective like Brunnstrom, and physical therapists are gifted by Brunnstrom. Actually, it's a very good gift for physical therapists from Brunnstrom. Saint Brainstorm's assessment can be effectively used to predict recovery or predict functional improvement in the stroke patients. And of course, functional independence measure can also be used to predict functional improvement. And I would like to add one more point here. Don't forget about ICF, International Classification of Functioning Disability, okay, and health. So you have to always evaluate the voluntary movements, functional improvement, sensory motor. You have to even give importance to sensation, and then try to fit it into the body structure and function component of ICF. and activity limitation component, and even into the participation, social integration, or participation restriction, what the patient has got. So once you treat the patient in the early phase, and if the patient shows some improvement either in the body structure or function, activity, for example, very early you can use 5 repetition sit to stand test, and this can assess the activity limitation what the patient has got. This can be applied to all age groups, even for the young stroke and geriatric patients. This can be tested in geriatric patients as well. So the activity restriction, if you have tested the functional 5 repetition sit to stand test, and if the patient in the second day is able to do 5 repetition sit to stand, and is taking 30 seconds to complete the task. After a week, patient is able to do 5 repetition sit to stand in 10 seconds. So now the activity component, the patient has improved. Only then you can say the patient is functionally recovering. Yes, of course, ICF has to be used along with the other assessments and functional skills.
Okay. I think Mr. Arun got some answer from this. Doctor, one more doubt. Is there any difference between the type of stroke? Meaning, you have mentioned some scales for the recovery prediction. Is there any difference between ischemic and hemorrhagic stroke?
Actually, you mean ischemic? You're asking about ischemic and hemorrhagic.
Yes.
Okay. So the early therapy, what a therapist can effectively start is only for ischemic stroke, only for ischemic stroke. And in the advanced world, we have a drug called TPA, tissue plasminogen activator, which all neurologists will try to give within 3 hours period or 1 hour period. And if a physical therapist can assess a patient very early, ischemic stroke patients can be started, can be put into rehabilitation very early. Whereas hemorrhagic stroke, the hemorrhagic stroke patients normally they won't be allowed to sit for first 5 days. And in case of the bleed is very small and the neurologist is ready to allow the therapist to handle the patient, yes, of course, you can also start early rehabilitation
Exactly.
for hemorrhagic stroke patients also. But don't forget, hemorrhagic stroke, even though it's fatal, if the patient has got very, very small bleed and the patient recovers, he will have full recovery early. But if the
Mm.
bleed is very large, most of the patients they won't be able to participate in therapy. They'll have poor cognition, so they won't be able to have very good functional improvement. And there is study that says 21% of patients will die with a larger bleed. And
Mm.
ischemic stroke, and there is a study done by Benhard in Australia, Julie Benhard in Australia. What she says is early rehabilitation for ischemic stroke can be started in 24 hours. That's what he tries to explain with AVERT. There is an
Mm.
AVERT rehabilitation, a very early rehabilitation, and a very, very early mobilization done for ischemic stroke patients. What they found is even though starting therapy within 24 hours is not a valid thing for stroke patients, but in 6 months time or 1 year time they will show better recovery than a person who started exercise little late. And it all in the hand of neurologist. The neurologist will decide when to start rehab for stroke patients.
Yes, of course. Okay. Thank you. So next question is, Doctor, why recovery very slow at upper limb than lower limb? The question asked by Mr. G.P. Gugendra.
Okay. So what they say is the cortical representation. The cortical representation, you have the face representation and the hand representation areas are more when compared to the lower extremity cortical representation. You know homunculus, physiological homunculus. So the hand representation and the arm representation areas more, and the middle cerebral artery, which is the artery which supplies major areas of the cerebral hemisphere. And very often, this middle cerebral artery is affected, and the hand representation, cortical representation is going to be larger when compared to lower extremity. That's why they always end up in upper extremity involvement more than the lower extremity involvement. Whereas
mm,
in anterior circulatory stroke, there the lower extremity representation is going to be more effective because anterior circulatory supplies those sites. But the anterior circulatory stroke is very rare. Emboli can travel into the anterior circulatory, whereas if you take middle circulatory, the diameter or lumen is almost equal to the internal carotid artery. So an emboli enters into the internal carotid artery can easily move into the middle circulatory, and very often the wedge-shaped lesion can be seen in the scan very in ischemic type.
mm. Okay, thank you. Next question asked by Mr. Muhammad Kaisi. How I can restore my previous smooth walking well?
Can you repeat the
How I
question?
can how I can restore my previous smooth walking well? So if the
Can you
patient has stroke more than 6 years,
more than 6 years?
yes, more than 6 years.
Okay. So what we can do is first evaluate the tone of, for example, lower extremity. I'll start with lower because you asked about walking. So
Yes.
evaluate the tone of lower extremity and test the passive elongation. So test whether the rectus femoris is tight, IT band, iliotibial band is tight, or is the medial hamstring is very spastic. Only component of hamstring, medial hamstring, is the spastic muscle. And then calf muscles. Check the resting length or passive elongation of the calf muscle. So first, stretch all these musculatures. Test and then stretch all these tight musculatures. And then you can first try with task-based training, like what I explained for the acute and early subacute phase, like sit to stand task. So that can be applied. So sit to stand task can be tried. So in case if the patient is not able to walk and circumduction, the patient has got circumduction because of increased tone, then there is another technique what the NDT practitioners commonly apply in chronic stroke. What you can do is you can use two high tables. Now don't allow the patient to use their hands, so the patient should not hold on to any rail or anything. So he has to keep the hand flat against the table, and the table should have movable wheels. Movable wheels.
Mm,
Now keep a towel. Keep a towel on the floor and put the affected extremity on the over the towel. The affected extremity of the patient should be on the table on the towel. Now
okay.
you are going to support the patient. The other therapist is going to move the table. Now the symmetry is going to be maintained. He is going to equally weight shift to right and left side. Now instruct the patient to bring the unaffected extremity forward. Now don't allow the patient to flex the affected extremity. Don't allow the patient to flex the hip and knee. Just ask the patient to slide the foot forward against the floor. Now, the symmetry is maintained both right and left side, even through the arms. Now, he is not going to do circumduction. Try
Mm,
this for this particular patient. Do a video before starting therapy, and also do a video immediately after therapy. Compare, and also do follow-up assessments. So many assessments has to be done because here it's 6 years stroke, so the patient
okay.
would have learned a lot of compensation.
Good idea. Thank you, doctor. The next question asked by Mr. Dimas Aji. Why we can't do passive movement on glenohumeral joint more than 100 degrees?
Okay. Normally, scapulohumeral rhythm. If a person wants to lift the arm by the side or forward, the scapula should also contribute during shoulder movement when a person wants to move the arm actively. But here, the patient has got weakness in the affected side. Now, if you are not going to consider the scapular mobility, you are going to just move the glenohumeral joint alone. Now the scapular mobility is going to be restricted, so it is going to be somewhere fixed. Patient is going to put weight onto the scapula. Now you are going to pull or push the segment up. So that is going to cause injury to the soft tissues or to the musculatures
Mm,
straight away. Our capsule may tear. So as far as possible, don't give passive exercise above 100 degrees. Or you can also stop with 90 degrees.
mm, mm, mm. Thank you, doctor. Next question asked by Madam Monica. Hi, Dr. Shanta. About functional electrical stimulation treatment, in which stage of sensory condition that are best to apply? One. Second question, sensory absent are only best to apply on the patient with sensory impaired. Once again, I'm
Um,
reading the question. Shall I need to read the question once again?
yes.
About the functional electrical stimulation treatment, in which stage of the sensory condition that are best to apply? That is first question. Second question said sensory absent are only best to apply on the patient with sensory impact.
Okay. So, in case if the patient has got a reduced sensation, test pinprick, test the pinprick, and you have to test the forearm, the extensors, the plexus, the extensor component, and the palm and hand. In case if the patient has got a reduced sensation, nothing wrong. You can start electrical stimulation very early, very early. At least you will be able to improve the range of motion using functional electrical stimulation. In case you see uh, the sensation has lost completely, then of course there is a risk in giving electrical stimulation, but nothing wrong. You can try functional electrical stimulation in the early subacute phase, but see that the intensity is not increased much. That might cause burns, but it is advantage. What advantage we have with FES is we'll be able to maintain the
Mm.
movements of the wrist. That is very important. As for if for the lower extremity is concerned, if the sensation is only mildly impaired, nothing wrong. You can start functional electrical stimulation, which with very early started can improve dorsiflexion, eversion function, and that will highly help the patient to walk in a good way.
Good. Thank you, Monica. Thank you, doctor. Next question is by Mr. Abel. How much percentage possibilities stroke patient can reach to stage 7 recovery?
I
He's
cannot.
asking about the
I,
possibility.
yeah, I cannot tell possibility, but um, only few patients. I'm not going to give you percentage. Very few patients. If the embolic stroke is not going to affect a larger area, and the patient is treated very early. Already I mentioned about Altiplace drug, TPA, tissue plasmagen activator. So if that drug is given to the patient early, that patient might recover to the fullest. And then hemorrhagic stroke, if the bleed is very small, I have seen so many patients who has reached stage 7.
Mhm. Thank you, doctor. Next question by Ms. Maheshwari Jagan. Early mobilization is the best or trunk control exercise than extremity exercise is the best in acute stroke rehabilitation. So he is asking which is the best one, early mobilization or meaning trunk control exercise. Which is the best one to start at the early
So
stage?
she wants to know whether the
Which one
trunk.
is the best? Which one is need to be start at the early stage? Early mobilization means trunk control. Uh, yeah,
Yeah.
he's
So
asking which one is the best.
if you use the term mobilization, just bringing the patient to sitting very early is also mobilization. So that is a
Hmm.
mobility thought to patient in bed. And trunk control exercises you are going to teach the patient later. Okay, but what I would say is early mobilization is a good therapy that can be given to all stroke patients. And if the trunk control exercise, we have to evaluate the patient. Not all patients won't need this type of trunk control exercise. That's what Janet Cott, Robert Shepard insisted to bring in the balance exercise with the task based. So if you take mobilization, that will become more of task based.
Okay, thank you, doctor. That was the last question. Okay, thank you all viewers. Having a wonderful session with you all. So don't forget to be followed. So if you want further updates about the upcoming webinars, so you can very well watch our Facebook. Or also, if you are if any students are watching, if you are interested to start your career or continue your career, so you can very well come to our university to watch our facilities. So you know that we are offering three stages of program in physiotherapy, diploma, degree, and masters. In masters itself, we have two, meaning part-time as well as full-time degrees. Uh, so also, if you want further information, you can watch our website www.mahsa.edu.my. So thank you for being with us. Have a wonderful weekend. Thank you.
Thank you very much.
Thank you very much.